हेलो एवरीवन, सो लेट्स डिस्कस द क्वेश्चंस फ्रॉम टुडेज INI-CET एग्जाम। तो पहला क्वेश्चन है कि इनडायरेक्ट इम्यूनोफ्लोरेसेंस इमेज अभी देखो इसको कैसे समझेंगे। सपोज ये दीज आर योर एपिडर्मल सेल्स। नाउ इन द एपिडर्मल सेल्स यू हैव प्रोटीन्स कॉल्ड DSG1 और 3. If you try to visualize them directly by applying stain testing, but if you test the antibodies against these in the blood of the patient, that is called indirect immunofluorescence. So this is a DIF image that had been given, and the question that was asked is what I've told you. Now there was an image where there was an ulcerated lesion. I don't know whether on the tip of the nose or near the medial canthus it was there, but they had asked whether it was a BCC or an SCC. Let's try to understand this. See, what happens is if you have an ulcerated lesion with waxy pink pearly nodules or rolled borders. So an ulcer with rolled borders which are also pearly, that is BCC. I think that was given. And there will be central ulceration. Okay, there can also be a non-healing ulcer. Okay, non-healing ulcer within growth, or there can be a superficial scale. This is how your BCC is going to look, and your SCC, which you'll commonly see on the face, will appear. See, it's more like a nodular lesion. Okay, you can see it on the lower lip, or you can see it on the face. So this is how it'll look, and melanoma is entirely a different story. So I think they had asked BCC from records that have collected. Most of the people had said that a BCC was asked in the exam, and this is a repeat. Which of the following is non-scarring alopecia? I mean, are non-scarring alopecia? So we know that alopecia and telogen are non-scarring. Now again, a patient came to the ER with fever, chills, body aches. Most of the students have recollected that the image of an eschar was given, so they have made it scrub typhus. Now another clue to the fact that they might have asked about an eschar or scrub typhus is the fact that they've asked it before also. And INI or AIMS people have a tendency to repeat their questions. Now dark neck was given from most of the recalls that I've got. It was Acanthosis nigricans. If you have any other interesting options that were there, just let me know. But from what I've been able to recollect, it was a simple question of Acanthosis nigricans. Now another simple question, have you seen your shirt's collar? So if I try to make a shirt here, the collar is raised. Okay, if you have, this is a little raised. It's a very zoomed in image of a PR patch which has a collarette of scales, and from what I have got is that collarette of scales was asked along with the fact that Christmas tree pattern was given. So in Indian skin you do not see it that clearly, but if you've read about it and if you've seen 2-3 patients, you'll be able to make out that this is Christmas tree pattern. Alright, so this is seen in psoriasis rosea or PR. This is a story that I just put 2 days before the exam, and a lot of students texted me saying, "Ma'am, yes, you had put that story and that came in our exams." Now, I always tell this that DSG1 is superficial. It's first, it comes first. DSG3 is a little down below. Now if you have antibodies against DSG3, there is a split just above the basement membrane that's called a suprabasal. We'll see something called as, the cells would be arranged in the form of a row of tombstones. This is, when somebody dies, you put a stone. That similar stone is row of tombstones. So you see this, and there was also some people are saying oral and body blisters were given. So this is all seen in pemphigus vulgaris. This is a very commonly asked question and a very easy one. In case you guys don't understand the difference between pemphigus vulgaris, bullous pemphigoid and the rest of it, just hit me up on Instagram and I'll try to explain this to you. It's a very easy thing. Don't try to understand a lot, but just know the difference between vulgaris, foliaceous and bullous pemphigoid, and you'd be good to go. So this was a very easy question. AIMS is always asked one question from the vesicobullous disorders, and derma I think is incomplete without these blistering diseases, so that's a very good question to ask as well. Now, another question that a lot of you have recalled is that they had asked about this one. I'm going to use blue color. Yeah, so they had asked about an 18-month-old baby with CNS symptoms. There was history of painful genital ulcer 1 year back. Now, the thing is, varicella and CMV do not usually cause genital ulcers because varicella in adults might cause genital ulcers, not in a baby. It's very unlikely to cause genital ulcers in a baby, and CMV will cause genital ulcers, usually in an adult. So I'm not in an HIV positive adult. So I'm not saying that everything, but if I were to choose one answer, I would go for HSV too, because HSV is very notorious to cause genital ulcers. Plus, it causes something called as temporal lobe meningitis or molarate meningitis. So this is what it causes, and with CNS symptoms, temporal lobe epilepsy, I would not. I would not go for the other answers. I would go for HSV2 here. Now, white lesion on the tongue which cannot be scraped off. This is leukoplakia. I don't think we should have any doubts about this, because this is like a very common repeat question. Now, in case you have any doubts or any corrections that you would want to put across, just go to passionate_dermatologist on my Instagram and do let me know. If you want to know more about me, my page, IG page, is where you should head to. Thank you everyone for watching. All the best for your results.